Welcome you all to this Women Health and Harmony series. We have already covered 2 or 3 topics earlier, and today I'm here to cover next 2 or 3 topics on infertility or subfertility, and I will be talking mainly on basics of subfertility or infertility today. So infertility in the broad sense is defined as inability on the part of a couple to procreate in spite of 1 year of unprotected sex. So anytime a couple gets married and does not use any contraceptives, 50% of the couples will conceive at the end of 6 months. Around 75% of the couples will conceive at the end of 9 months, and 85% of the couples will conceive at the end of 1 year. And if 15% of the couples who fail to conceive at the end of 1 year will be labeled as subfertile or infertile by WHO definition. And if you further give these couples a chance for the next 1 year, the remaining 5% out of 15% will still conceive, and in that case the incidence of infertility would be around 10% at the end of 2 years of unprotected sex. Infertility is broadly divided into 2 different types: the primary infertility and the secondary infertility. Primary infertile couples are those couples who have never conceived any time after marriage, and secondary infertility couples are those couples who have conceived earlier but now fail to conceive for next 1 year of unprotected sex. So either they have conceived with an abortion earlier or a normal delivery earlier. So these are the broad headings of infertile couples. But there are certain factors which actually govern infertility in a given population, and these factors are the age of the husband, the age of the wife, the frequency of coitus, and the duration of exposure. So these 4 factors actually really govern fertility status of an individual or a couple. If you look at overall incidence of fertility or infertility, the incidence of infertility all over the world is around to the tune of 15 to 20%. And in India, the incidence is rising gradually, and as per the WHO estimates, every 4th couple in India is likely to be infertile in near future. If you look at the causes of infertility, they are broadly divided into causes in the females, causes in males, and there are certain factors which are combined both to females and males. Around 1/3 of the factors are present in females, 1/3 remaining are present in males, and remaining 1/3 are combined factors both for males and females. So, and if we understand the causes in females, there are many factors which can cause subfertility or infertility in females, and those are the factors broadly divided into depending on the organ where it is actually lying. So it may be vaginal factors, cervical factors, endometrial factors, tubal factors, ovarian factors, and there are higher centers and pituitary gland, the master gland, which governs all these reproductive functions. So the main causes could also be lying there. So similarly, there are many causes of male infertility or subfertility, but we broadly dividing them into 3 major causes. The first and foremost important thing is the abnormal semen parameters. The second one being the basic fault or the primary fault lying in the testicles, known as a primary testicular failure. And finally, some number of patients will have secondary testicular failure, where the testes do not function optimally as a result of certain other causes related to other endocrine organs and higher centers of the body. There are many factors which predispose or act as risk factors for fertility, because today the population is growing at a faster pace. People are ambitious, there is industrialization, people are often exposed to oxidants and many factory chemicals, and so many factors are there, and few of these factors are important for us to really understand, and if we avoid them, then we will be minimizing the risk of infertility or subfertility. And one of them is smoking. It adversely affects or it has a great impact on fertility status of the couple. Then chronic alcoholism, sexually transmitted diseases, extreme obesity, lifestyle damages, and you need holistic approach for these kind of conditions. And another important factor is the work stress or the mental pressure on the couples, which may lead to erectile dysfunctions or sexual dysfunctions. Now you need to really investigate these couples whenever they come to you for subfertility or infertility, and there are certain set of basic investigations on the females and certain basic investigations on male. As far as the females are concerned, you should go into the details of the history, find out any major illnesses or any disorders in the past, any surgical procedures which are performed, especially on the abdomen, any laparoscopies which have been performed, or any metabolic disorders which were present, or there are certain conditions which are present congenitally in these particular patients. And then we must also do a thorough clinical examination that will involve systemic examination, general examination, abdominal examination, and bimanual pelvic examination. So, and the basic tests which are required to be done in a female infertility couple would be to go ahead with complete blood count, a routine urine analysis to identify certain major illnesses if they are present, and then certain hormonal profile which has impact on infertility status or fertility status of an individual, things like thyroid profile, and another hormone which is very important and which needs to be investigated is serum prolactin. This is a hormone which is a pregnancy hormone, but if it is present in the non-pregnant state, can create a bit of havoc in fertility status of an individual. And then there are certain tests which can be performed as specific tests. So there are specific tests for cervical factors, specific tests for uterine factors, specific tests which can be done for tubal factor, and specific tests done for ovarian factors, which will involve tests for ovulation. So if you look at the tests which are done for ovulation will be to find out whether that particular patient is ovulating in any given cycle. So there are many tests which can be done to find out whether ovulation is occurring or not, and one of them is serial follicular studies. So ultrasound is a basic investigative modality which is available for most of the gynecologists, and if you start doing follicular studies by transvaginal scan in these patients from day 3, day 4 onwards, you can see the follicle growing, and a time will come whether that particular follicle will rupture, and that will result into ovulation. So serial follicular studies will help in identifying ovulation. Then there are certain blood tests which also can help in, so something called LH surge. LH surge occurs 24 hours before the expected time of ovulation. So serum LH levels will identify whether this particular patient has ovulated or not. And as soon as the ovulation occurs, the follicle which has ruptured, which will develop into a corpus luteum, and it will start producing a hormone known as pregnancy hormone, the progesterone, which helps in sustaining the pregnancy. And if you look at serum progesterone levels on day 21 of a 28-day cycle, and if they are more than 9 nanograms per ml, you can certainly document that this particular patient has ovulated and the serum progesterone levels are within normal limits. And finally, if nothing works, then finally an endometrial biopsy, which is done on day 1 of menses, will tell you whether there is a progestational effect and which will confirm ovulation. So there are many tests which can be done to find out tubal factor for infertility, and few of them are the most commonly done is hysterosalpingogram, where usually this particular investigation is done in a radiology clinic, where an obstetrician or a gynecologist or an infertility consultant goes there. He puts in the instruments in the cervical canal and inject a radio-opaque dye through the cervical canal, and the X-ray technician or a radiologist will click an abdominal X-ray in the EP plane to find out or to visualize the uterus and fallopian tubes, and it will give us idea whether the dye is spilled into the peritoneal cavity. And the next commonly performed test on tubal patency is known as sonosalpingography or saline sonosalpingography, where the saline is injected through the cervical canal. The saline gets passed through the uterine cavity into the fallopian tube, and the saline is spilled into the peritoneal cavity, and sonologists take real-time pictures of this particular procedure, and will give you idea about the uterine cavity, the size and shape of the uterine cavity, the pathologies if they are present in the uterine cavity, and it will delineate the fallopian tubes, and it will also give us idea whether the saline is spilled into the peritoneal cavity, signifying that the fallopian tubes are nicely patent. The third commonly performed test is a chromoperturbation, which is done at diagnostic hystero and laparoscopy, another investigative modality for infertility management. We usually don't resort to this particular test as a primary investigative modality because this is is an invasive procedure. It needs anesthesia, it needs a highly qualified laparoscopic surgeon, and you need the basic laparoscopy equipment to perform this particular test. And the fourth test was the old test, which was performed, also famous for last 50 to 75 years, known as Rubin's test or air insufflation test, where the dye or the saline or methylene blue was not used, but air was used, and the air was flushed through the cervical canal into the uterine cavity, and a hushing sound with the help of stethoscope could identify whether one or both the fallopian tubes are patent. So these are 3 or 4 tests which are available for tubal patency test. One more test which is available commonly for uterine factor of subfertility or infertility is a diagnostic hysteroscopy. So where a fine telescope with 30-degree forward oblique or 0-degree telescope, which is used under anesthesia, is put inside the uterine cavity, and you can visualize the entire uterine cavity, the walls, the pathologies, the endometrium, and the tubal openings into the uterine cavity known as tubocorneal recesses. So any normality or an abnormality of the uterine cavity can be delineated and diagnosed with the help of a diagnostic hysteroscopy. So this is the test which is available for uterine evaluation. So a male also needs to be investigated on certain lines, and one simple and one single basic parameter which the male has to give is a detailed semen analysis. This particular analysis is done usually after 3 days of abstinence, and the semen is being analyzed by an expert pathologist, and certain criteria are laid down regarding the volume, the motility, the count, the number of abnormal or normal sperms, and presence or absence of infection, which will give you an idea about a normal or an abnormal semen parameter. So this is one particular test which is extremely important in males, and usually it suffices as long as it is normal. Let's go on to the basics about management of an infertile couple. So in general, health of the male partner as well as the female partner has to be good and sound. Their general nutritional status should be good. There shouldn't be any major vitamin deficiencies, and if there are any major vitamin deficiencies, should be treated. If you're dealing with thyroid or prolactin abnormality, then it should be taken care, because these are common conditions which go hand in hand along with an infertile patient, and a treatment modality is so simple and the results are usually gratifying. In the next presentation, we will probably cover advances in ART procedures or reproductive technology procedures, where we will be covering something like controlled ovarian stimulation with intrauterine insemination, and in vitro fertilization or intracytoplasmic sperm injection or ICSI procedures. So these are high-tech procedures and which will be covered in detail in the next video presentation.